cranial nerve assessment. But this is not a regular cranial nerve assessment. In school or in college, in your college and your courses, any courses you attend, any of the courses you attend, cranial nerve assessment, not the regular one. Usually, traditionally, in our bachelor's time, they try to teach us cranial nerve assessment. But what really happens is they try to memorize these things, and it won't stay with you for much long. This is not what they teach you. Traditionally, they try to memorize it, but it is not helpful. It's not about memorizing, but it's all about understanding the story. And I have a story to tell you. See, I'm Leno. I'm giving courses based on the physiotherapy related content and medical related contents, and I will upload this continuously on my YouTube channel and also share these contents in my Instagram. The inspiration behind, the vision behind this, all of this is that I believe that we need to prepare for a life, not for an exam. And that's what we are trying to do here. Let's start with the cranial nerve assessment. The first cranial nerve that we need to look here is olfactory nerve. What does olfactory nerve actually do? When you see the function of olfactory nerve, it's simple, that it just helps you to smell. And when you assess the cranial nerve assessment of olfactory nerve, you're just trying to see whether the patient is able to smell it or not. If you see Parkinson's disease, in early phase, in early onset of Parkinson's, they have an reduced ability to sense the smell, and this is an indication of an early symptom of Parkinson's. When you see the anatomy of the olfactory nerve, it's really this picture right here is a familiar one. This look like two horns, but this is actually the same thing in this. Right, this is olfactory tract with an olfactory bulb. The smell come from here. Good, nice food is cooked here. The smell come from here directly to the olfactory mucous membrane. It will be taken up from the olfactory bulb to the olfactory tract. This is the olfactory tract and into the brain. Anosmia is when we call it as your ability to smell is gone, then we call it as anosmia. We cannot just say it's a nerve when you give a smell that is familiar to the patient and ask the patient to close their eyes and ask them to identify the smell. That's how you test the olfactory nerve. Something that's similar to that, they might be knowing the coffee powder smell, peppermint, any of that. You give the patient and ask him to identify it. Close the eyes of the patient, you give the smell and ask him to identify the smell. The thing is, we cannot say just it's the nerve that's affected. What if the nose is blocked? And what if the patient has COVID, sometimes even after head injury? So that is the first nerve, olfactory nerve. There is 12 different nerves. The second one is optic nerve. Now, this is actually really funny. I believe when you try to assess the optic nerve, the second nerve, you need to be really, really looking into three different areas or three different concepts. When you look into the eye of this patient, I'm looking at the pupillary reflex. I'm looking for the visual acuity and the visual field. What do I mean by pupillary reflex? Pupillary reflex is what happens is your eyes pupil size will change depend on the light it comes in. Right. If there is a lot of light comes in, the pupil will try to constrict, because you don't want a lot of light go into your eyes, so the pupil will constrict. If there is less light outside, your eyes will try to bring in more light, so it will open. This is very crucial. Understand this. When you give a pupil a light to the eye, directly to the eye, a flashlight directly to the eye, the pupil will constrict, because you don't want, there's a lot of light coming from outside and you don't want that much light, so the pupil will constrict. But if there is less light in your room and if there's more light need to become and more light need to be entering the eyes, the pupil will dilate. That is this pupillary reflex is actually happening. But when you see the pupillary reflex, the anatomy behind it is that I'm talking about pupillary reflex in optic nerve. The sensory afferent nerve is optic, but the efferent nerve is oculomotor. The sphincter is constricting and causing the contraction here, right? So this is going in is sensory and coming out is oculomotor nerve. I will tell you how this really happens. This picture is really important. There is direct and consensual reflex. I will explain it. So what happens is that light comes in through the eyes. Here light comes in. It will go through this. There is two field. Okay, this is nasal field and temporal field. So nasal field is here is the nose. Here is the temporal part. So then the area that crosses nose is called the nasal field, and this is a temporal field. Anyway, so the vision from both this nasal and the temporal field go through the optic nerve. See the optic nerve? It goes. See, the nasal of the one eye go to the opposite side, and the temporal will go to the same side. Understand that? The nasal of the one side will go to the opposite side, and the temporal will come to the same side. Same as here. The temporal part goes here. The opposite nasal part goes here. The crossing. So this crossing part we call it as optic chiasma. Very important point. Now the nasal part is coming here. The temporal part from the temporal vision is going there. And here, this is all optic nerve. Optic nerve is coming. There's one crucial point. This is called pretectal olivary nucleus. Now from here, there is two branches going of the same here. It going two branches. This is very important. See, from here, one eye it is going to two different opposite side also. Because of this, what happens is, even if you give light reflex to one eye, the other eye pupil will also constrict because it is interrelated. There is a connection between both eyes, right? From the pretectal olivary nucleus, it will goes to Edwinger-Westphal nucleus. From there, this is the red thing, right? The red thing is oculomotor nerve. I told you, sensory is pupillary, sensory is optic nerve, and the efferent, the motor component of it is coming from the oculomotor nerve. And see where is the red line is going? This is the sphincter pupillae, which will help in the construction of the pupil, right? So this is sensory is optic, and the efferent is olfactory. This is a reflex arc, right? So this is a direct response. Direct response is nothing but when you show the light, the reflex is happening in the same eyes, and there is an signal is coming from the same side. But when you opposite eyes will also show the same thing. That is what we call consensual reflex. In addition to the direct response to the stimulus in the eye, there is also a stimulation, contraction of pupil in a non-stimulated eye. This is known as consensual pupillary reflex, right? The first thing is pupillary reflex. Okay, when I see optic nerve, I'm looking for pupillary reflex. Next thing, what I'm looking for is just a visual acuity. What do I mean by visual acuity? It's just the clarity or the sharpness of the vision. It's like when there is no acuity, you need to put the specs, because it's just the vision that you need to see and read. That we will look through a Snell's chart. That you stand at 6 meters away and you try to read the Snell's chart. The patient should be able to read it out. And if patient is not able to read it out, that means patient cannot see. The clarity is not there. There is no sharpness in the vision. Acuity is lost. So what we actually do in this test is actually funny, because you put first in 6 meters, then you change it to, if patient cannot see, you reduce the distance, and based on that you calculate the visual acuity of the patient. So that is the third one. Now let's go to the last and final one. You look in the optic nerve, that is visual field, how wide you can see, area that can be seen when these eyes are fixed in one direction. And the fact is that when you assess the patient, it's not you're looking entire area. You are focusing in this one single point. At the same time, you are able to see this point, this point, this point, and this point. The examiner sit directly facing the patient at eye level. Both the examiner and the patient cover one eye. So if I sit from the opposite side, I need to close my right eye, and the patient should close the left eye, and the patient should be looking at my nose, and its eyes should not go anywhere else, just focus on my nose only. And I am going to show my hands on visual stimulus in different quadrant, and ask him to see whether the patient is able to see. And you need to be upper and lower quadrant, temporal and nasal field, you need to show them. So basically the idea is to see how wide they are able to see the field of the vision. And this is done by you're sitting, you're closing your right eye, ask the patient to close his left eye, and then you need to ask the patient to look it in your nose, and you are going to give visual stimulus in different superior, inferior, the nasal field and temporal field, all these areas you're giving this, and ask the patient whether they can see it. It's just checking the how wide is their visual field. Three different things: pupillary reflex, visual acuity, and visual field when you come to pupillary, when you come to optic nerve. So this is the different muscles of the eyes. We'll come into later. Next is pretty closer to a lot of time what happens is the visual field of the optic nerve get confused with the oculomotor, trochlear, and abducens nerve, which we look at it in the one single go. Why is this happening? Because I used to think that this thing is similar to what we do in optic nerve. Optic nerve is not checking the muscles. Optic nerve is checking the vision, the field, how wide you can see. In the oculomotor nerve, keep this in mind. When you're checking for oculomotor, trochlear, and abducens, you're checking purely motor. How is the muscles around the eyes working? That's what you're checking. How is the muscles around the eyes working? For that, you need to ask the patient to move their eye in an H pattern. Whereas when you check for optic nerve, and when you check the vision of the wide area of the vision, you are actually not moving the eye. You are asking them to focus in a one single point and see the how wide is the vision. But here, when you check for oculomotor, trochlear, and abducens, you ask the patient to move the eye in an H pattern and see whether the muscle is working. Because I want to stress this, because I used to think that both of these are similar, but it's not. Right. To understand this, you need to understand different muscles and which nerve is supplying. So you are asking the patient to look here, you need to ask it to look here, then you're asking to look here, look here, look here, look here, all the way like an H. So when I move my eyes, when I move my eyes to this side, that is lateral rectus working, this muscle working. And when I move my eyes this side, it is a medial rectus, so it will be, nose will be here. So when I move my eye this side, this is my medial rectus working. And when I move my eyes in the superior part, that is superior rectus and inferior rectus, then there is inferior oblique, then inferior oblique and superior oblique. What most of the time when you look for oculomotor, these muscles has become any problem with these nerve, oculomotor, trochlear, abducens nerve, this eye movement will be affected. There will be a problem with your eye yield, and if eye yield problem is there, you are going to see ptosis, something like this. The eyes will be almost closed. How will you check that? Now you come, you need to first, if you want to check this oculomotor, abducens, and trochlear nerve, you need to understand the muscles. So these nerves supply different muscles around the eyes. Let's get, this is the nose, right? So when you move your eye towards the nose, that you're checking for the cranial nerve 3 oculomotor, which is supplying the medial rectus. When you're looking at the up, that you're looking for the inferior oblique. This is nose. When you look upside of the nose, inferior oblique. This is down, nose, superior oblique. So if you see that, most of the area it is supplied by cranial nerve like a square. And here also, only thing is the superior oblique and the lateral rectus. Lateral rectus is you are abducting the eye, so it is an abducens nerve. Here superior oblique is trochlear, all other this oculomotor. It's pretty simple, guys. It's not a big deal. I used to remember, when you move your eyes towards nose, that is medial rectus. When you move away from your nose, that is abduction of the eye. What is lateral rectus? Lateral side of the nose, lateral rectus, abducens nerve. All others are supplied by oculomotor other than superior oblique. Superior oblique is actually down to the nose. That is by trochlear nerve. That's it. Others all are. This is superior rectus, inferior rectus, lateral rectus. Inferior oblique, superior oblique. Superior oblique is by trochlear nerve. Has come to the fifth nerve, trigeminal nerve. Trigeminal nerve. This is actually my favorite. And most of the time what happens is I used to get confused between trigeminal nerve and facial nerve, and between the optic nerve and the oculomotor, abducens and trochlear nerves, because the eye movements and the vision field, all of this I used to get confused. But once you understand the idea behind it, it becomes more clear. When you look for optic nerve, you are looking for three different things. What is it? Pupillary reflex, the visual acuity, and the visual field. Sometimes people look for fundoscopic assessment also, but it is not required for us. And then what we are looking for once you're in the oculomotor, trochlear and abducens, you're looking different muscles. So let's say I will tell in this guy's face where is the muscle. This toward this movement will be medial rectus, that is applied by oculomotor. This will be inferior oblique, that is applied by oculomotor. This movement down eye, that is trochlear nerve. That is which muscle? That is superior oblique. This is abducens nerve, which is that movement, that is lateral rectus. This is superior rectus. This is inferior rectus. All of them are by third cranial nerve. Only this is by abducens nerve, and this is by trochlear nerve. That's it. That is the idea of abducens, trochlear and oculomotor nerves, right? Now we come to the trigeminal nerve. It's actually really important to remember that jaw jerk and corneal reflexes are in the trigeminal. All others you are going to remember, because what happens is there is sensory, there is facial, sensory, three different points you need to see, and there is muscles of chewing. So there is in the trigeminal nerve, there is reflexes checking. We are checking for reflexes, we are checking for sensation, and we are checking for the motor movements. When I say motor component, it is chewing muscles like masseter is also involved. What are the three different branches? When I say ophthalmic, maxillary and mandibular, I'm checking for sensation, purely sensory, light touch and prick. So ophthalmic branch is in the forehead, maxillary branch is in the cheek, and mandibular. Can you tell me ophthalmic? Here is ophthalmic. Where is maxillary, and mandible? It's that simple. Maxillary is cheek, ophthalmic is forehead, mandible is lower jaw. The motor branch here is temporalis and masseter. I ask the patient to clench the teeth and see if there is any wasting and all that. Corneal reflex is something that you do. You take one cotton and ask the patient to look somewhere away, and you slightly touch the cornea of the eyes, and you see the reflexes. The afferent is through ophthalmic and efferent is through facial nerve. Right. So you don't want to go for there, but you're checking for the different reflexes. The two different reflexes in the trigeminal nerve that you need to be conscious is the corneal reflexes and the jaw jerk reflexes, right? And the three sensory, to summarize the trigeminal nerve, there's sensory, that is ophthalmic, the maxillary, and the mandible. This part is mandible, this is maxillary and ophthalmic. You look for pinprick sensation, looking pinprick pain, and touch sensation, light touch. You're looking for jaw jerk and corneal reflexes. Next we will see the facial nerve. Facial nerve, when you understand that, it's actually I will say I was seeing many patients with Bell's palsy, and you need to understand that people confuse Bell's palsy with the stroke, because what happens is the difference between Bell's palsy and stroke and facial nerve is when something like Bell's palsy come, it is mostly peripheral, right? Peripheral nerve is getting involved. So what happens is both upper and lower quadrant of the face muscles will be affected. I will show you this area and this area, this entire area will be affected if it is Bell's palsy. But if it is stroke, if stroke is happening this side of the brain, the opposite side, lower quadrant only will be affected. So that is an upper motor neuron lesion. Contralateral side, lower part is will be affected. That is stroke. If entire side, one side area of the muscles is getting affected, that is Bell's palsy. When you come to understand the Bell's palsy, there is 5 different branches: the temporal, the zygomatic, the buccal, the marginal mandibular, and the cervical. Temporal area, the frontal, the temporal area, the zygomatic, the buccal, the mandibular, marginal mandibular, and the cervical. One more time: temporal, this is the zygomatic, the marginal mandibular, the buccal muscle is here. And each of this area, it is telling the complete area, but all of these is muscles. Nasalis is here, orbicalis, oris is here, mendalis is here. So each of this area there is muscles, and each of these muscles are supplied by facial nerve. So when there is a facial nerve involvement, any of the facial nerve, let's say Bell's palsy or inflammation of the facial nerve, these muscles will be getting affected. So I will tell you, when you compare this facial nerve and trigeminal nerve, facial nerve is mostly motor. It's a motor thing, and there is an anterior two-third of the tongue of the sensation is coming, but mostly that is motor, right? So when you look for the facial nerve, that is motor, but when you look for the trigeminal in the face, that is sensory. 3 different branches: temporal, zygomatic, and the temporal, ophthalmic, and mandible. That is 3 different sensory branches of the trigeminal: temporal, the ophthalmic, and the mandible. Whereas in the facial nerve, it is purely motor in the face, that is the temporal, the zygomatic, the buccal, mandible, marginal mandibular, and the cervical. And there is sensory for the facial nerve also, that is anterior two-third of the tongue. And there is autonomic function related to the lacrimal gland, the tears that comes out of your eyes when you cry, that is also by facial nerve. Because when you come to the parasympathetic innervation of submandibular, sublingual, and lacrimal glands, through its chorda tympani is a greater petrosal nerve, and its greater petrosal nerve is a branch of facial nerve which is supplying all of these submandibular, sublingual, lacrimal glands. So when you see facial nerve involvement, there can be these type of problems also. So just to make you clear one more time, facial nerve, when you look at the face, look for the deviations of the muscles, where primarily motor muscles will be involved. And there is 5 different branches: the temporal, the zygomatic, the buccal, the marginal mandibular, and the cervical. But in the trigeminal, in the face, you're looking for sensation and reflexes. What reflexes? Corneal reflex and corneal reflexes and the chin. Here you will give a tap in the chin and the jaw jerk will come. The jaw will try to close. That is the reflexes you should come. It is not coming out. Jaw will try to close. That is trigeminal. What is the sensory point? The temporal, the the ophthalmic, and the mandible. This is the 3 different branches of the trigeminal. If you want to go back and show you, I can show that. See the ophthalmic, the maxillary, and the mandibular. Did I say something wrong? Yeah. See, this is the ophthalmic, the maxillary, and the mandible. 3 different sensory points. Next comes the vestibular cochlear nerve. It's actually funny that there is it is related to whether your hearing is there, still your hearing, you can hear, are you deaf now, and related to the balance. Cochlear component is related to the balance, and for that we can test Rene's test and Weber's test. And when you look for Rene's test, you're looking for conduction, whether your air conduction is good. Because when you have a tuning fork of 512 hertz, 512 hertz, and you're putting it in your back of the ear in the bone, and it's still vibrating. Once the vibration stops in the ear, you are putting it in the air, like you hold it outside your ear. If the patient is still hearing, that means his air conduction is better than bone conduction, right? So you take a tuning fork and you hit it in your hand. There is vibration. You put it behind your ear in the bone area, and you feel the vibration. The vibration stops. You put it outside and keep it here. The patient can still hear. Air conduction is much better. The cochlear component is still working. It's that simple. That is Rene's. That is Weber's test. Rene's test. That is Rene's test. When you look for the vestibular part of that, you are basically looking for the balance component of the patient, and that you can do Romberg test, you can look for a stepping test, you can head impulse test, this Halpake manner. All of this is done to test the patient's ability to balance themselves in a scenario. In Robert's test, what you're trying to do is that you ask the patient to just stand with the closed feet together, both the feet together, and you can ask the patient to close their eyes and stand and balance themselves. You're just trying to check the balance to see the how well the patient is able to balance themselves. That is a vestibular component. This Halpake maneuver is like benign paroxysmal position vertigo. In patient has a vertigo related problem, you actually do this Halpake maneuver. You just turn the patient head to the opposite side, and from sitting to, you put the patient directly to a supine lying, and you are seeing for nystagmus. Head impulse test is also something similar to like that, and stepping test is also something similar to that. You're checking for vestibular component. Wait, since the time limited, we cannot explain all of that. Accessory nerve, again, this is from the 11th cranial nerve. You're checking for the two muscles here, sternocleidomastoid and the upper trapezius. You ask the patient to elevate the shoulder, and that is for the trapezius, and you ask the patient to turn their neck to one side, that is the head to the one side, that is the sternocleidomastoid. You ask the patient to turn the head to one side, and you give resistance to it to check the sternocleidomastoid muscle, and you ask the patient to shrug the shoulder up to see the trapezius strength for accessory nerve assessment. The final ones are glossopharyngeal and vagus. This is checking for, you can check for whether the patient is still able to swallow food. You can check for the gag reflex. All of this is related to the vagus and glossopharyngeal nerve. The last one is hypoglossal. Here you're looking, ask the patient to move their tongue to different side and see whether they are able to move. Hypoglossal nerve in its essence is trying to see whether the tongue movement is still possible. Right, that is the nerve component of it. I will tell you this. It doesn't matter, hypoglossal nerve or the glossopharyngeal vagus nerve doesn't make a big change, and you know it. Most of the people know this is something related to gag reflex, something related to swallowing. This is related to tongue, right? Accessory nerve, everyone knows, sternocleidomastoid and trapezius. The problem comes in the facial nerve, trigeminal nerve, optic nerve, oculomotor abducent, and trochlear. If you get that idea of that and differentiate these, this is more of the core of the physiotherapy related cranial. This you need to master it. All others are not a part of. I will say, okay, you identified, but you cannot do anything about it, right? Swallowing and all, you cannot do anything about it. This is actually speech and therapist people's job. You can identify it, but most of the time you need to see these facial nerve, Bell's palsy, stroke, and these cranial nerve assessment, Georgia corneal reflexes, trigeminal nerve, optic olfactory. These things you need to identify much better and faster. Even the vestibular part of that, balance things, and the accessory nerve. Okay, so that is the idea, that is the core idea you need to understand. If you want, we can upload one practical video also with the cranial assessment. If you're new to this channel and if you're finding this helpful, please subscribe to our YouTube channel and follow me on Instagram at @therapist.leno. Keep learning and keep moving. Thank you guys. Bye.